Good afternoon, everybody. Hello.
Good afternoon. Hello.
Okay, this is me, Muhammad Abdullah. I'm a postdoc at the Hong Kong University. I'm going to be the chairperson of the current session. Welcome all to the Southeast Asia IEDR 2021, and we hope we can have a fruitful and interesting session today. I just want to confirm that everyone can hear me well and they can see me as well. And we are going to test the mic and the headphones and also the camera for everyone. And it's easy to share the screen as well. If every person can just share his screen right now.
Yes.
Just like testing before we start the session.
Okay.
As you receive the information by email that every poster presentation will take around 3 minutes, then we will have like 2 minutes for discussion. Any questions can be just raised maybe in the chat box, and then I will tell this question to the presenter. After 5 minutes, then we will move to the next presenter. I hope that all the presenters are here. Right now, I can see.
Yes, I can hear you.
Yes, our first presenter is Dr. Kimberly Joyce.
Yes.
Yes.
Hi. Good
Hi.
afternoon.
Can you just please try to share your screen?
It says that the host disabled participant screen sharing.
Okay, just a second. Let me check.
Thank you.
I'm just trying to reach the technical team because I think we are disabled to share our screens right now.
Okay, thank you.
At least maybe all the participants can try to share their video and as well as the unmute themselves and test the mic as well. Dr. Peilu has not joined yet. John Tay. Okay, let's wait for the other participants to join and the technical team to allow us to share our screens.
I think it's okay na. Miss Flores, Dr. Flores.
Yeah, I think now we can share our screens.
All right, let me try. Yes, I can share my screen.
Okay. So Cambry, as you are the first presenter, you can share your screen.
Okay, hold on.
Okay.
There, can you see my screen?
Yes.
Can you hear me clearly, sir?
Yeah, we can hear you and we can
Okay.
see.
All right, thank you. I'm gonna stop sharing.
Yes.
Okay. Thank you.
Let me share my screen. How about, can you see my screen now?
Yes, it's successfully
Oh,
shared.
sorry,
Yes.
sorry. It is, okay, can you, okay, I will stop. Right.
Can I share my screen?
Okay.
Can you see this?
Yes.
Yeah. We can see the screen shared.
Okay, so stop sharing for a minute.
Okay. So Dr. Peilu, is Dr. Peilu with us? Dr. John Tay? No, not yet. Dr. Panacha Weir-Poole?
Yes, I'm here.
Yeah, have you
Okay.
shared your screen?
Okay, let me try.
Yes, please.
Can you see?
Yes, great.
And can you hear me clearly?
Yes, and we can
Okay.
as well.
Thank you.
I think Dr. Liliko, you have shared your screen. Dr. Lilia?
Yes, I'm done.
Oh, okay. Cheng Lu?
Yes, I'm here.
Yes, hi, Dr. Cheng. Can you share your screen, please?
Okay. Now, can you see my screen and hear
Thank
me
you.
clearly? Okay.
Yes. Dr. Zin Shu?
Yes, I'm here.
Yes, can you share your screen, please?
Yes, I think the previous presenter need
Oh,
to
Oh, yeah,
stop sharing. Okay,
Oh,
thank you.
sure.
Let me try. Can you see it properly?
Yes, great.
And is it magnified properly?
Yes.
Okay, thank you very much. So I will stop sharing. Thank you.
Okay, Dr. Yan Pin Fan.
I'm here.
Yes, can you share your screen, please?
Okay. Can you hear me clearly?
Yes, yes, yes.
Okay, thank you.
Yeah, I think now we are all set. We have 2 minutes and we can start with Dr. Kimberly Joyce. Dr. Kimberly, are you here?
Yes.
Okay. Just get prepared.
Okay. Should I start sharing my screen, sir?
I think we
Not
still
yet.
have 1 minute, but yeah,
Okay.
you can start sharing your screen and just
Okay.
get ready.
Okay, thank you.
Okay, Dr. Kimberly, you can start your presentation. Please unmute yourself.
All right, can I start?
Yes, please.
Okay. Good afternoon, everyone. I'm going to present my study, Factors Affecting Patient Referral from General Dental Practitioners to Periodontists. So in this study, we aim to determine the factors that affect the referral patterns of Filipino general dental practitioners, or GDPs, to periodontists. This is because the identification of such factors that influence the decision of general dental practitioners to refer patients to these specialists to the periodontist could serve as a basis for developing a more efficient and systematic periodontal referral process. So for this study, we used a self-administered survey among 75 general dentists practicing in the city of Manila, Philippines. We collected data on the GDP demographics, periodontal referral patterns, clinical and non-clinical factors that may influence patient referral to a periodontist. Descriptive statistics, specifically frequency and percentage, were employed to identify the primary factors that influence periodontal referrals to the specialists. So for the results, you can see here in the table and figure that among the 75 respondents, 61.3% indicated that they treat periodontitis patients as part of their general dental practice, while 80% of the GDPs would prefer to refer periodontal patients to a specialist, with 76% having estimated that they refer about less than 10 patients per month. And the type of periodontal condition and the patient's systemic condition were the top cited clinical factors that affect referral of patients from GDPs to the periodontists. Other clinical factors that were considered by the GDPs are the pocket depths, degree of mobility, amount of bone loss, and the severity of bleeding. So among the non-clinical factors, GDP cited that the willingness of patients to cooperate with treatment, the GDP's perceived personal skill in managing periodontal patients, the specialist's postgraduate training, and the GDP's proximity to a periodontist are the ones that they consider when referring patients to periodontists. Therefore, we were able to conclude that there are multiple factors that affect the decision of general dentists practicing in the city of Manila in referring periodontal patients to a specialist. These include both clinical and non-clinical factors. The primary clinical factor considered was the type of periodontal condition, while on the other hand, the top non-clinical factor was the patient's willingness to cooperate with treatment. Thank you.
Thank you for your interesting presentation, Dr. Kimberly.
Thank you.
Is there anyone have questions? You can directly unmute yourself or write in the chat box and I can read the question. Okay, Dr. Kimberly, I have one question. Like, have you considered the difference between the skills and expertise of the general dentists? Like, some general dentists may have more skills and more expertise that they can just handle or manage the periodontal cases, while other general dentists may prefer to refer these cases to a specialist. Have you considered this variation in the skills between the general dentists?
Sorry, let me unmute myself. Yes, sir, we have considered those factors. On the survey questionnaire, we asked if the general dentist practices periodontal treatment and also the likes. We also considered if they would prefer to refer even though they still practice perio.
Yes. Thank you so much, Dr. Kimberly, for your presentation.
Thank you so much.
Any questions? Okay. Then we will move to our next presenter.
All right, let me stop my share.
Yes, can you stop your sharing screen? I will start sharing my screen. Okay, can you see my screen?
Yes, I can see.
Yes.
Okay, I will start my presentation right now. In this presentation, I'm going to introduce the synthesis and characterization of calcium strontium silicate cement to be used for potential dental applications. We have noticed that there's an increasing demand and interest among the dentists and specialists toward the conservative and regenerative dentistry, such as vital pulp therapy and preserving tooth structure, then proceeding with interventions like endodontic treatment and other non-vital therapies. The available materials right now that can be used for this purpose was the MTE and calcium hydroxide. But due to the drawbacks of the MTE and calcium hydroxide, such as longer setting time, poor handling properties, and the dissolution rate of the calcium hydroxide and the higher pH values, which impairs the cellular growth. We have thought about developing a material that can overcome these drawbacks and have better bioactivity and higher biocompatibility, and that can stimulate as well the differentiation of the human dental pulp stem cells toward the odontoblast for the deposition of the dentine barriers. Strontium is one of the divalent cations that has an interesting properties and has the potential to increase the bone deposition and inhibit the bone resorption, as well as it can stimulate the differentiation of the human dental pulp stem cells, also the resistance to the hypersensitivity as well, and high radio opacity of strontium. So we thought of incorporating or doping the strontium into the calcium silicate crystalline structure to develop a material that can overcome these problems. So the objectives of our study was to synthesize the novel calcium strontium silicate and to investigate the bioactivity and the biocompatibility of the material, as well as some physico-mechanical properties and the differentiation of the human dental pulp stem cells. Our methods and results that we have prepared the calcium silicate and calcium strontium silicate through the sol gel method, and then we characterized the powders by the XRD, which revealed that the conventional calcium silicate the major patterns were the dicalcium silicate and tricalcium silicate, while the calcium strontium silicate was a new crystalline structure that has been formed of calcium strontium silicate. The zeta size distribution of the calcium strontium silicate was in the average rate of 86 nanometers, which is considered as a nanomaterial. And the pH values were significantly lower in calcium strontium silicate than the calcium silicate. Also, the epitite formation in the calcium strontium silicate was higher than the conventional calcium silicate at both time points, 1 day up to the 28 days after immersion in the PBS solution. And the FTIR spectra confirmed the formation of the phosphate and carbonate groups, which are the characteristics groups of hydroxyapatite formation. Finally, we investigated the differentiation of the human dental pulp stem cells through the alkaline phosphatase activity and alizarin red stains, which both proved that the calcium strontium silicate has higher alkaline phosphatase activity, which was significant after 14 days. And the alizarin red stains as well, the mineralized nodules and the calcium deposition was significantly higher in calcium strontium silicate than in calcium silicate. So finally, we concluded that the calcium strontium silicate was successfully developed and synthesized by the sol gel method, and it has proven to have or to show an enhanced bioactivity, in vitro bioactivity, of course, and the higher differentiation of a human dental pulp stem cells than the conventional calcium silicate. Thank you very much. Is there anybody have questions?
Hi, Dr. Mohammed.
Yes, hello.
Yeah, and this is very interesting study. So I was just wondering, what is the clinical application of your materials? And because I didn't find the comprehensive strength in your study, so do you use it as a pulp capping agent, or are you going to use it as a restorative material?
No, we have already tested the compressive strength. But it was around 45 to 50 megapascals. We are intending to use the material in the vital pulp therapy, not a restorative material, because the compressive strength is not much sufficient for a final restorative material, but it will be used as a vital pulp capping in retrograde filling materials and also in regenerative treatment after the revascularization. So it will be mainly as the capping material.
Oh, thank you.
Thank you so much. Okay, now we will go to our next presenter, Dr. Pei Lu.
Can you hear me, everyone?
Is Dr. Pei Lu here?
Can you hear me?
Yeah, but yeah, I think your voice is a little bit far. Can you just raise your voice a little bit?
Sure.
And you can start sharing your screen.
Can you see the screen?
Yes. Hi, Dr. Lu.
Hello, everyone. Today, my topic is design and development of oral health promotion app for adolescents. Today, I will only report the topic guide construction of a
Oh, sorry, the screen is not shared yet.
Not share? Sorry.
Oh, yes. Yes, it's successfully shared.
Okay, sorry. Today, my topic is a qualitative study of a design and develop an oral health promotion app for adolescents. Why we choose adolescents? Because dental problem is still very common in adolescents, and the adolescents' prevalence of gingivitis and caries and oral behavior is not very satisfying in Hong Kong. And the cohort study showed that the oral health status worsened from childhood to early childhood in Hong Kong. And most important, the dental care service provided by the Department of Health in Hong Kong is not available in middle school in Hong Kong. So why we choose the app as a health delivery strategy? The app have many advantages which maximize the potential for supporting health behavior change intervention. And when we develop the app, the first stage is to sketch the app idea. So we can, through qualitative study, we can get what are the unique features of your app and how to competitive in the market. So we designed a qualitative study to get the opinion and perspective and your preference of design an app. And our objective, methodology. The topic guide was first drafted based on a narrative literature review on mobile health promotion among adolescents, and we interview 4 students aged 12 to 18. The interview was recorded, and we used this item to develop a topic guide. And we use this topic guide to do a pilot test with 3 focus groups. 6 key areas were constructed: the strengths of the app against other existing oral health promotion strategies, design oral health related information and contents to included in the app, function of the app, and the prototype and the interface design of the app, and the data protection for users and the effective promotion strategy among adolescents. So through this through these 3 focus groups, we have some preliminary results, and we know they need the function of the app, including they want to have the app have the function of self-examination on the caries gingivitis, and the app can give a diagnosis. And they also need caries risk assessment, and some students want to solve some problem they encounter, and they want the app to give the personalized oral health recommendation and a reminder system to promote the oral health. That's all. Thank you.
Thank you, Dr. Pelo, for your interesting presentation. Is there anybody have any question? Okay, thank you again, Dr. Lu.
Thank you.
We will move to our next presenter, Dr. John Tay.
Yep.
Yes, Dr. John, can you please share your screen?
Okay. Thank you.
Okay. Thank you so much.
Okay, so this is a systematic review that we did, which looked at healing complications and their detrimental effects on bone gain in the area of vertical guided bone regeneration. So we know that healing complications after vertical augmentation can influence the surgeon's choice of bone grafting. So what we wanted to find out from this review were two things. The first, we wanted to know what was the ratio of means of vertical bone gain when healing complications occurred versus when uneventful healing took place in patients with vertically resolved ridges that require dental implant placement. And the secondary aim of this review was to investigate the incidence of complications after vertical GBR and the influence of the timing of implant placement, namely staged versus simultaneous GBR, and the kind of regenerative devices used, and what their influence was on complications that occurred. So after establishing these focus questions, this review was conducted according to Prospero guidelines and keyword search of 3 databases for randomized and controlled clinical trials, prospective, retrospective case series. A hand search was done as well, and outcomes included patient and site level ratio of means of vertical bone gain between those complications versus uneventful healing, as well as the incidence of complications that occurred after the GBR. So we conducted random and fixed effects meta-analysis, as well as quality of evidence rating using a grade approach. So the results show. So from the results, we included 36 studies for both qualitative and quantitative analysis. And what we found from the review was that the ratio of means of vertical bone gain was 0.65 and 0.62 when membrane exposure and abscess formation occurred respectively. So what this means is that when membrane exposure happens in vertical GBR, you will expect to regenerate only 65% of the bone. And when abscess formation is around 62% as well. The overall incidence of healing complications at a patient level was relatively low at 10%. And then when we looked at subgroup analysis of wound dehiscence and abscess formation, this was around 7.7% for wound dehiscence and 0.9% for abscess formation. We also found out that if you place the implant simultaneously together with vertical GBR, this resulted in a slightly higher incidence of complete failure of the entire graft and the implant at around 2.12% compared to staged placement. When we looked at neurosensory alterations, this was relatively low at 0.5%. The reason for this was partly because a lot of these vertical GBR papers didn't use block grafts. They used very conservative means of harvesting bone. So conclusion-wise, limited evidence shows that membrane exposure and abscess formation results in a reduction of around 40% of bone gain after vertical GBR when compared to uneventful healing. And the overall incidence of post-surgical complications was relatively low at 10% on a patient level. Simultaneous placement of implants during vertical GBR also results in a slightly but significantly higher incidence of complete graft and implant failure. Okay, thank you very much.
Thank you, John, Dr. John. Any questions? I think I have one question to you, Dr. John.
Yes.
Have you investigated that, or how you found that the membrane type could affect the complication or the prognosis? Like,
Yeah. Yeah, so it was very interesting because when we looked according to a regenerative device, there weren't any statistically significant differences. But interestingly, when they looked at resorbable membranes, it trended towards an increased risk of complications. Now, this is very, very odd because we know that anecdotally, non-resorbable membranes are meant to have more healing complications. This result was actually quite echoed by an urban systematic review 1 or 2 years ago as well, which showed similar findings. And they hypothesized that when they use non-resorbable membranes, perhaps the clinicians had more experience and were very much more careful in their handling of their flaps. So maybe that's why these results occurred.
yes. Okay. Thank you, Dr. John. Thank you
Thank
for
you
your
very much.
presentation. Can you stop your sharing your screen, please?
Will do.
Our next presentation is Dr. Pancha Weerapol.
Okay, I'm here. And can
Yes.
I share my screen now?
Yes, please.
Okay, let me set. Okay. And can I start now?
Yeah, please start.
Okay. Hello, everyone. I am Panacha Weerapol. I'm from Chulalongkorn University of Thailand. Today, I would like to present my research project, the prevalence of mild cognitive impairment among elderly dental patients and oral health-related factors. First of all, mild cognitive impairment, or MCI, is a transitional stage between normal cognition and untreatable dementia. And many studies found the relationships between oral health factors and dementia. Some suggest a causal relationships and some claim as a modifiable risk factor. So this study aimed to find the prevalence of MCI among elderly dental patients who might have higher risk and to find any oral health factors that might be related to this preventable stage. And this study decided to be a cross-sectional descriptive study. After we enroll potential participants who age 60 and over, we exclude anyone with current depression and dementia by screening case, and we got total 248 participants as we calculated for prevalence study. And firstly, we used Montreal Cognitive Assessment Test or MoCA test for MCI detection. Any participant with MoCA score under 25 will be defined as MCI in this study. And after that, we do an interview and oral examination, and we perform chi-square and independent student t-test as a univariate analysis. And after that, we perform a logistic regression. For the results, average age of all participants was around 69 years old, and most of them were female. And we found 73 out of total participants were MCI. And as you can see in these two bar charts, it shows the result from univariate analysis, which means what factors that MCI group and normal group has significantly different. For the oral factors, there are complete edentism, periodontal disease, having less than 20 natural teeth, and having less than 4 posterior occluding pairs. And also for the age, marital status, education, occupation, obesity, hypertension, and social media using. And after that, we perform a logistic regression, as you can see in the last table. We found that MCI was significantly associated with age over 70 years, obesity, non-social media user, and having less than 4 posterior occluding pairs, which make 1.8 times higher risk to develop MCI. To conclude, the prevalence of MCI among elderly dental patients was 29.4%, which is higher than general elders, and the oral health factors significantly associated with MCI was having less than 4 posterior occluding pairs. Thank you. Any questions are now welcome.
Thank you so much, Dr. Panacha, for your presentation. Any questions, please? Okay, Dr. Panacha, what was the correlation between the MCI and the dental problems? Like, how did you correlate between the MCI and the presence of some dental problems in those patients?
For the univariate analysis, did you mean that?
No, I
Oh.
mean, like, what is the relation between being an MCI patient and having some dental problems?
There are like many theories that cannot conclude it yet right now. But firstly, there are like inflammatory process that can from periodontal disease that can produce more tau protein in the brain. That's the cause of Alzheimer's disease, one type of dementia. And the other hand, there are like every time we chew or when we have mastication, there is a stimulation to the brain to make it like have more blood flow and oxygenation. And yeah, is that answered?
Oh, yeah, understood.
Okay.
Right now. Because I misunderstood before when I read the abstract. Now it's very clear. Oh,
okay.
Thank you so much.
Okay, well, one question here. In the conclusion, you said that MCI was related to the missing teeth, yes? So did you also look at the reason behind for the tooth loss?
Yes, but I want to make it clear what kind of tooth loss that really affect to MCI.
Yes, it could be due to caries, parodontitis, or other reasons. I think that's important to make. Okay.
Okay, thank you very much.
Okay, thank you, Dr. Pancha.
Thank you.
Can you stop sharing your screen, please?
Okay, thank you.
Okay. Now we can move to our next presenter, Dr. Lilia Ko.
Yes. Good afternoon.
Good afternoon, Dr. Lilia.
I'm Dr. Lilia Ko from Philippines. Okay, my research is about the oral health assessment of children in a charity institution. Objective, we want to determine or assess the oral health condition of children in this institution and formulate recommendations. For the methodology, a descriptive study was used to determine the oral health status of the 46 children in the institution. The interview method was used to gather information about the demographic factors, oral hygiene practices, diet, and length of stay of the children in the institution. The oral examination was done through the use of mouth mirror and spoon excavator. All data were collected and recorded using the WHO form. The result of the study, among the 46 children, 22 male children had 80 decayed teeth, 2 exfoliated teeth, and 0 filling. And for the female children, 24 of them had 52 decayed teeth, 26 exfoliated teeth, and 0 filling. Proposed treatment, we have 39% will need restoration, 40% will need extraction, and all children will need topical fluoride application. For the conclusion, the study revealed high level of untreated dental diseases suggestive of inadequate oral health care. There's a need for implementation of oral health program for the prevention of dental caries. And this must be done through the collaboration of professionals in the healthcare services. That's all. Thank you. Any question?
Thank you, Dr. Lilia, for your presentation. Any questions?
Do you also look at the periodontal condition or not? Because the title is oral health assessment, so only covered caries, yes?
Yeah. There are no serious periodontal problem, though I have some children with dental plaques.
Okay, thank you, Dr. Lilia. Can you please stop sharing the screen?
Yes.
Okay, our next presenter is Dr. Wen Jiago.
Hello.
Yes, hi, Dr. Wen. Uh,
Hello, everyone. The topic I'm going to share today is relationship between periodontal status and cognitive function of rural elderly in Taizhou. Periodontitis, as one of the most common oral disease, is associated with many systemic diseases. Systematic reviews showed that there may be a two-way relationship between periodontitis and dementia. However, there are few studies on periodontal status and cognitive level. Moreover, the number of missing teeth is often used to represent periodontitis in domestic relevant studies, which is not accurate. As a subcohort of Taizhou cohort, the Taizhou imaging study is a good platform to study the relationship between periodontal status and cognitive function of the elderly in rural China in terms of population representativeness and cooperation. Our objects are to investigate the oral health status of the Taizhou imaging study, compare the differences of periodontal health status between different cognitive function groups, and explore the correlation between periodontal status and cognitive function. The Taizhou imaging study was followed up in 2020. The social demographic background, health behavior, and general health were collected through questionnaire survey. MMSE and MoCA were used to evaluate the cognitive function. According to the method recommended by WHO, the status of crown and root caries was collected by 4 mouth examination. Periodontal examination was performed in half mouth randomly, including GBI, CI, PD, and CAL. Then our results. A total of 547 subjects were included in this study, of which 17% in the normal cognitive group, 58% in the undefinable group, and 24% in the impaired cognitive group. The prevalence rates of crown caries, root caries, and the severe periodontitis were 94%, 36%, and 54% respectively. The calculus index and clinical attached loss in the normal cognitive group were the smallest among the 3 groups, and the difference was statistically significant. The results of our multivariate analysis shows that dental calculus index, education level, occupation, and drinking history were the related factors of cognitive function. To conclude, the overall periodontal condition of the Taizhou imaging study was poor, while a quarter had cognitive improvement. In terms of periodontal condition, only calculus status were significantly correlated with cognitive function. That's all. Thank you.
Thank you, very much for Dr. Wayne for your presentation. Any questions?
What is the criteria to define the periodontitis or severe periodontitis?
Sorry, please.
What is your criteria to define what is the no, mild, moderate periodontitis and severe periodontitis?
We use the CDCAP classification.
Because you based on the half mouth only, yes?
Yeah. Because we base on half mouth, so we use the CDCAP classification, but it is halved.
Okay, thank you, Dr. Wen, for your presentation.
Thank you.
Can you stop sharing the screen, please? Now we move to our next presenter, is Dr. Cheng Lu.
Okay, I will share my screen.
Dr. Wen, can you please stop sharing the screen? Oh, yes, thank you. You can start, Dr. Lu.
Yeah, I can start now. And good afternoon, everyone. I'm Lu Chen from the University of Hong Kong. And today my poster topic is the management of fear and anxiety in dental treatment under local anesthesia, a systematic review and meta-analysis. So first, Dental anxiety is identified as a negative and unwanted emotion for dental treatment. Patients recognize dental treatment as a very dreadful procedure and often cannot control themselves. The prevalence of dental fear and anxiety varies in different countries, with estimates ranging from 5 to 20%. Fear of local anesthesia injection is one of the most common fear reported by dental treatments. It is very imperative that the local anesthesia injection can be admired to the dental patients in the context of the treatment of patients' fear. So the management on dental fear and anxiety needs to be flexible and requires understanding among patients and dentists. However, no sufficient evidence could be found to draw a firm conclusion whether it is effective for patients under local anesthesia under those interventions that can be more comfortable by the interventions. To figure out, we have performed a systematic review and meta-analysis. We include 12 randomized control trials in our study, and we found that anxiety levels decreased more in the intervention groups than in control groups, but no significant difference in vital signs such as heart and pulse rate and pain levels between the intervention and control groups. And there was difference between two groups for patients under 18 years old, while there was no such difference in adults. So to draw the conclusion, our study suggested that the intervention for dental fear and anxiety for the dental patients under local anesthesia might be effective, but they did not influence the adults, and it did not influence the pain level and the heart and pulse rate. So the clinical question of whether to use interventions for dental treatment and which intervention was recommended cannot be answered by the result of our systematic review. The quality of the included studies could be improved, and the long-term effects of improved attitude when facing local anesthesia were needed. To establish more evidence-based conclusions, we need further and high-quality research adopting long-term design. So, and that's all. Thank you.
Thank you, Dr. Lu. I have one question, please.
Yes.
Have you noticed during the systematic review collection of data, what kind of interventions that have been applied to minimize or reduce this fear or anxiety? What's the difference between the different interventions?
Yeah, that's the good question. For the interventions, we included almost different kinds of interventions, such as the audio and the visual interventions. We play music or during or before the treatment, or watch cartoons during the treatment. And also, we have some behavior guidance, such as we teach the patients how to face the dental fear and what will happen in the next treatments. So that's the interventions we included in our study.
And you didn't find any significant difference between the type of the intervention? Like if, for example, the audio intervention could be more effective than watching cartoons?
Yes. I did not put the results in my poster, and if you are interested in this results, we can communicate by email, and that's a good question. We can talk later.
Yes, sure. Thank you so much. Thank you, Dr. Liu.
I have one question here. So I'm curious about the LA, local anesthesia. My question is whether local anesthesia per se could enormously increase the fear and anxiety of dental treatment.
Sorry?
The sharp needle, local anesthesia per se may cause the potential fears and the problem.
Yes, I know. For the children, we avoided them to seeing the sharp needles, right? And in one of the articles we included, they designed a new type of the needles that children cannot see the needles. They can only see the doctor with something without a sharp needle. So they also find out that this is decrease the dental fear, right? And for some of the experiment, they only included adults, and they teach them that what way they are going to do, and even show the videos of the local anesthesia. So that also infects the results of our study. And this is a good question. I think I can study in the later studies. Thank you so much.
Thank you.
Thank you, Dr. Lo, for this interesting presentation. Our next presenter is Dr. Zhen Chu.
Yes, I'm here.
Yeah, hi, Dr. Zhen. Can you share your screen?
Yes, of course. Thank you very much. Okay, can you see the screen properly?
Yes, yes.
Okay, the present systematic review and meta-analysis aim to summarize the current information regarding mastigatory performance, including chewing efficiency and bite force of stroke patients. An electronic search was conducted in 4 databases and yielded over 3.8 thousand records after removing the duplicates. Finally, 9 studies corresponding to 11 papers and around 300 participants met the inclusion criteria, and 5 studies were included for meta-analysis. Maximum bite force was compared between stroke patients and healthy persons, which is figure 2. And between the 2 sides of the same stroke patient, which is figure 3. Pooled results showed that the maximum bite force of stroke patients was significantly lower than the healthy individuals, but no significant difference was detected in the self-comparison of the ipsilegional and contralegional side. 2 studies were included in the analysis of chewing efficiency as presented in figure 4. The result indicated a poorer mastication of stroke patients compared to the healthy individuals. Basic neurological knowledge is needed for understanding the result of this review. The motor innervation of the masticatory muscles is provided by trigeminal nerve. The trigeminal motor nucleus receives projection from the bilateral brain motor cortex nearly symmetrically, then send the signals to the ipsilateral masticatory muscles. Unilateral lesions do not necessarily produce weakness of masticatory muscles, as the contralegional cortex may compensate for the impairment at least partially, if not completely. Therefore, compared with healthy controls, stroke patients generally have reduced bite force, but insignificant difference was found between the ipsi and contralegional side. As for mastigatory performance, the deterioration is more distinct compared with reduction of bite force. Possible explanation is that mastication is a complex process. The sensory motor control involves multiple cranial nerves and sequential contraction of a series of orofacial muscles. Unlike trigeminal nerve, which receives signals from bilateral hemisphere, hypoglossal and facial nerve cross the midline to the lower facial muscles and tongue on the other side. If an infarction happens at the unilateral motor cortex, the contralateral side can hardly compensate for that loss. Therefore, we concluded that maximum bite force of stroke patients is lower than that of healthy individuals, but no significant difference between the ipsilegional and contralegional side. Chewing efficiency of stroke patients is only about half of that of healthy persons, which is more severely affected compared to the bite force. That's all from my presentation. Thank you very much.
Thank you, Dr. Cho, for your presentation. Any questions?
Could you highlight what is the key difference between the overall oral conditions between the 2 groups? The stroke patient versus the controls.
That's a really good question, because that is one of the main confounding factors that will influence the comparison result. But actually, fortunately, among the studies that we included in this review, most of the studies had controlled these confounding factors, which means the participants in both groups share the similar oral condition, general oral condition, and they have similar age, gender distribution. Thank you very much for that question.
Thank you, Dr. Chu, for your presentation.
Thank you.
We can move to our next and final presenter, Dr. Yan Pin Fan.
Hello.
Yes, hello.
Okay, I will share my screen now. Hello, everyone. My name is Fan Yanpin. I'm from the University of Hong Kong. My study title is Association between Masticatory Performance and Oral Conditions in Adults, a Systematic Review and Meta-Analysis. Mastication requires coordination of lips, cheek, tongue, teeth, saliva, and so on. Difficulty chewing is a common problem. Therefore, this review aims to give an overview of the current evidence on the associations between oral conditions and masticatory performance. The review questions were: which oral conditions factors are associated with masticatory performance in adults? What are the direction and the level of the associations? 3 databases were searched. The outcome were oral conditions and masticatory performance, which were assessed by objective method. Studies which assessed masticatory function by subjective method were not included. Study design were cross-sectional. Methodology quality were evaluated. Meta-analysis was conducted by correlation coefficient. Finally, 61 studies reporting on 73 articles were included. 20 studies were included in meta-analysis. Among the 61 studies, 33 were evaluated as strong level of quality, 28 as moderate. Among the oral condition factors, the number of natural functional teeth, perioral muscle status, dental prosthetic status, and oral moisture status revealed positive associations with masticatory performance. Wearing dentures and poor periodontitis revealed negative associations with masticatory performance. Meta-analysis showed that oral condition factors with the strongest level of positive association was the number of natural teeth. Pooled correlation coefficient were 0.5, followed by the number of functional teeth, maximum tongue folds. The weakest association was oral moisturization. Pooled correlation coefficient was 0.11. Concurrence: number of natural functional teeth, perioral muscle status, oral moisture status, dental prosthetic status, and periodontal status are the main oral condition factors influencing masticatory performance. Among these factors, number of natural functional teeth have the strongest positive association. Thank you.
Thank you so much, Dr. Fan, for your presentation. Does anybody have any question? I have one question, like what was the most negative effect on the masticatory functions among your study groups?
There are 2 main oral condition factors which showed negative associations with masticatory performance: wearing removable dentures and poor periodontal status, such as periodontitis. Yes.
Yes. Okay, thank you so much, Dr. Liam Fan. Does anybody, we still have few minutes left. Does anybody have any question regarding any of the posters previous presentations? Okay, I just want to remind you all that just keep watching your poster presentations on the website of the IADR. May someone in the future raise any questions in the next couple of hours or couple of days, so you can answer the questions related to your poster's presentation. We can have like a screenshot all together. Can everyone just share his video screen? can have such a memorial photo. Yes, everyone is ready. Okay, 3, 2, 1. Thank you so much, and nice to have you all in this presentation. And we hope we can see you in the future IEDR meetings. Thank you so much.
Thank you, everyone.
Thank you, everyone.
Thank you, everyone. Bye-bye.
Bye.